Mr. Fitzpatrick, you recognized.
Thank you, Chairman Buchanan, for holding this very important hearing on investing in a healthier America by evaluating chronic disease prevention and treatment. Our nation invests less than 3% of our overall health expenditures on prevention services. All the while, there are 1.7 million people that die from chronic diseases each and every year, many of which are preventable. Moreover, about 42% of Americans have 2 or more chronic diseases, and as members of Congress, we should be prioritizing and investing in prevention and living healthier lives, hence the purpose of today's hearing. This is also one of the reasons why I co-led the introduction of the Personal Health Investment Today Act, also known as the FIT Act, alongside of our colleagues, Representative Kelly, Representative Panetta, Representative LaHood, Representative Sewell, and Representative Boyle. This bipartisan, bicameral legislation encourages physical activity and it incentivizes healthier living by allowing Americans to use a portion of the money saved in their pre-tax health savings accounts, HSAs, and flexible spending accounts, FSAs, toward qualified sports and fitness activities. Mr. Chairman, I'd like to submit for the record a letter sent to our committee as well as an attachment both from the Health and Fitness Association on the benefits of physical activity for preventative health and chronic disease reduction. My first question is for Dr. Hyman. Doctor, good to see you again. To quote your testimony, you state, quote, "We do not practice evidence-based medicine in America. Instead, we practice reimbursement-based medicine." Dr. Hyman, in your experience, what do you think Congress should do specifically to incentivize health outcomes associated with healthier living rather than reimbursement-based medicine?
Well, thank you, Congressman Fitzpatrick. Good to see you again as well. I think this is a critical question, and it's multi-dimensional, and I think we've covered a lot of these potential solutions. I think covering food as medicine within Medicare as a first step in nutrition services is critical. I think incentivizing providers to do the right thing by paying for nutrition services is critical. Dealing with the behavior change aspect by reimbursing, for example, group programs like the diabetes prevention program works effectively, even if it's delivered by a layperson. It's as effective as if it's delivered by a physician. And we saw this with the Saddleback Church. You know, people heal together. Community is medicine, referring to this peer support model. It works, and I think it's a very low-cost model. The patient I mentioned, Janet, she was headed for a heart transplant, which cost $1.6 million on average per patient. We spent a few $100s to put her in a lifestyle change program with a group that was effective in reversing her heart failure, reversing her diabetes. These are the kinds of things that need to be paid for. We had to kind of stick it together with Scotch tape at Cleveland Clinic by using shared medical appointment codes, required physicians to be involved, required higher-level providers to be involved. That's not necessary. These programs can be delivered in community settings like churches and can be reimbursed by the federal government for various programs. So I think by changing our incentive structures, by changing what we pay for, we can actually start to use the science to deliver on results that improve healthcare outcomes and reduce healthcare costs.
Thank you, Dr. Hyman. Mr. Chairman, I also want to highlight the importance of prevention services specifically for cancer. Currently, there are more than 1.7 million people who receive a cancer diagnosis every single year. Our committee has advanced legislation to increase Medicare access to multi-cancer early detection screenings. Many of us are on the Cancer Caucus, which I co-chair. We've also introduced numerous pieces of legislation. Dr. Peters and Senator Frist, in your experiences, what other investments, aside from early screenings, should be made to prevent further cancer diagnoses and to get our arms around this terrible killer in America?
Mm-hmm.
I think we're talking about so many things that will help. So reduction in rates of obesity will help, increase in activity, diets that aren't so unhealthy for you. And I do think we need to do more earlier cancer screening that doesn't involve tests that people don't want to go do. So the blood-based tests, if we can validate that they're helpful, that then people follow up on, I think are great ideas. But I think this fundamentally comes back to everything we're all talking about. The other thing I would add is that I don't get paid for treating prediabetes or obesity. And I need to get paid for those things, and I need to be able to use tools to help my patients take away their prediabetes and go backward to have normal glucose tolerance. So there's a lot that makes it harder for us to work in the system to do the right thing, even for our patients.
Senator?
I think focusing on cancer, we talked about chronic kidney disease a little bit earlier, and I think a focus on cancer does build out the model. I think what you've heard today from all of us is, and government has historically not been good at this just because we haven't had the data in the past, but it really is to take a more holistic view in terms of where a disease starting with prevention, starting with the root causes. And the root causes that we can control are lifestyle, because so much is determined by genetics, not so much by our healthcare system in terms of treatment, but really does come back to our lifestyle, what we eat, how we behave, do we smoke, how much drinking, opioids, and the thing we've concentrated on today is food, because it's low-hanging fruit. It's the sort of thing we can do. You mentioned, and I really applaud it, in terms of what this committee has done in terms of the prevention early diagnostic test. We're going to the root causes here, the diagnostic test. I think what I would encourage the committee to do next is to look at, once you get the test done, you lower access to those tests, and the communities that we've heard about, like rural communities, are a real challenge. But once you get the test, how do we act on that? In terms of the companies that I work with in the field, there's a huge gap between if you have a positive result or a negative result, what happens? How do you get to that facility, to that access hospital, critical access hospital, to the local hospital, to the hospital 2 or 3 hours away? And that's where an opportunity, that gap, I think, exists for things like, we've talked about it, telemedicine, patient navigation. You have to reimburse for that. You can't just talk about it. If you reimburse for that, I think it's a great opportunity that this committee and other committees can work on. Will have a huge impact in connecting the overall holistic view of starting with a person and ending with a disease and an outcome. We've stayed over with the outcome and the reimbursement and the value-based care. Now we need to build value-based care, not just out of the healthcare system, but all the way back to what health and well-being really is.
Thank you all for your time. I yield back, Mr. Chairman.